2. Introduction. Definition. Schizophrenia. Of all the psychological disorder, schizophrenia is one of the most severe psychopathology. Schizophrenia was first carefully described by Kraepelin, 1896. He used the term dementia praecox to refer to a group of symptoms which is now known as schizophrenia. The term schizophrenia was introduced by the Swiss psychiatrist Eugen Bleuler in 1911. Schizophrenia is derived from two words, the German word, schizion, which means to split, and the Greek root, phren, meaning mind. This derivation gives a sense of split mind. Bleuler identified that certain psychological functions such as language, thoughts, and emotions which are normally integrated are split or disintegrated in schizophrenia. Exact nature of schizophrenia remains disputed. However, the consensus is on the view that it comprises a number of disorders characterized by distortions of thinking and perception. Schizophrenia includes severe disturbances in thinking, speech, perception, emotion and behavior. Herz and Marder, 2002. It involves loss of contact with reality, bizarre behavior and distorted expressions. 3. Clinical picture. Symptoms of schizophrenia. There are two major diagnostic systems which provide criteria to diagnose schizophrenia: the ICD-WHO, 1992, DSM-APA, 2000. DSM is very comprehensive and popular among psychotherapists in diagnosis of schizophrenia. DSM-IBTR-APA, 2000 states that two or more of the given systems should be present for a significant period of time during a 1-month period: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior and negative symptoms. Only one symptom is required if the delusions are bizarre or the hallucinations consist of voice keeping up or running commentary on the person's behavior or thoughts, or involve two or more voices conversing with each other. Dysfunctions are found in various areas of life setting, especially in work, interpersonal relations, or self-care. Sign of disturbance prevailed for at least 6 months, with at least 1 month of symptoms from the list of delusion, hallucinations, disorganized speech, grossly disorganized or catatonic behavior and negative symptoms. Another way to diagnose schizophrenia is to examine which symptoms cluster together and to examine underlying mechanisms contributing these symptoms. Factor analysis of the signs and symptoms of the various subtypes of schizophrenia has identified 3 clusters of symptoms: disorganized, positive and negative symptoms. Little et al. 1994. The disorganized clusters is featured: be disorganized speech, behavior and inappropriate or flat mood. The positive clusters. Psychology paper number 15, Clinical Psychology. Incorporate hallucinations and delusions. Whereas negative symptoms are characterized by behavioral deficits like apathy, lack in motivation or poverty of speech. 3.1. Detailed explanation about the symptoms of schizophrenia. Positive symptoms. These are those that reflect an excess or distortion in normal behavior and experience such as delusions and hallucinations. In contrast, negative symptoms reflect an absence or deficit of behaviors that are normally present. Delusion. A delusion is a false belief about reality firmly held in spite of strong disconfirming evidence. It involves disturbance in the content of thought. Delusions are common in schizophrenia, occurring in more than 90% of cases at some time in their illness. Cutting, 1995. In schizophrenia, certain type of delusions are quite prevalent. Persons suffering from schizophrenia may have belief that their thoughts, feeling, or actions are being controlled by some external agency. Delusion of reference is also common among schizophrenic, where some neutral environmental event is believed to have personal meaning intended only for the person suffering from schizophrenia. Hallucination. A hallucination is a false sensory experience that occurs in absence of any real stimuli or event. Person affected by schizophrenia may see the objects or hear the voices that are in real have no existence. Hallucination can occur in different sensory forms: auditory, visual, olfactory, tactile, gustatory. But auditory hallucinations are more common, being present in up to 74% of cases with schizophrenia. Sartorius et al. 1974. Visual hallucinations occur less frequently, present in only 15% of cases, and tactile hallucinations are rare. Cutting, 1995. Patients can become emotionally involved in their emotions. In some cases, they may act on their hallucinations and do what the voices command them to do. Stern and Silbersweig, 1998. Negative symptoms. These are basically behavioral deficits. Important negative symptoms in schizophrenia include lack in energy and interest level, abolition, poverty of speech in which amount of speech is adequate but vague and repetitive, alogia, and lessening experience of pleasure, anhedonia. Kring and Arnest 1999 found that schizophrenic report less pleasure on questionnaire about hypothetical situation, food, recreation, sex, etc. But with actual situation like film they report equal like without schizophrenic. Flat affect and asociality are also part of negative symptoms. Flat affects are characterized by no emotional experience on stimulus, stare vacantly, face muscles flaccid, eyes lifeless, toneless voice. Flat affects are found in 66% of schizophrenic patients. Sartorius et al. 1974. Schizophrenic patients are severely impaired in their social relationship, asociality. Disorganized symptoms. Disorganized symptoms of schizophrenia are characterized by disorganized speech and disorganized behavior. Person affected with schizophrenia express problems in organizing ideas and in speaking so that a listener may fail to understand. Their speech may be disordered by loose associations. In work setting, schizophrenic patients may be seen wearing unusual dress like wearing an overcoat and gloves on a hot summer day. They may disregard their personal safety and hygiene. 4. Subtypes of schizophrenia. They may disregard their personal safety and hygiene. 4. Subtypes of schizophrenia. Schizophrenia is very heterogeneous kind of psychotic disorder, which encompasses a variety of disordered processes having different causes and effects. It makes complicated the diagnosis of schizophrenia. The DSM-IBTR recognizes many types of schizophrenia in which 3 major and 2 additional subtypes of schizophrenia have been categorized. 4.1 Disorganized type. This type of schizophrenia usually occurs at an earlier age. It is manifested by disorganized speech, disorganized behavior, flat or inappropriate affect, and no evidence of catatonic schizophrenia (DSM-IBTR). As the disorder progresses, the person shows infantile behavior. A silly smile and inappropriate laughter are common symptoms. Speech becomes tough to understand and include baby talk, childish giggling. Patients may have severe disruptions in their self-care abilities and inability to perform routine tasks. The prognosis of disorganized schizophrenia is generally poor. Treatment of disorganized schizophrenia is least effective and has a likelihood of modest gains. 4.2 Catatonic type. According to DSM-IBTR, in catatonic schizophrenia, the clinical picture is dominated by at least two of the following features. Immobile body or stupor. Excessive motor activity that is purposeless and unrelated to outside stimuli. Extreme negativism or mutism. Assumption of bizarre postures, or stereotyped movements or mannerisms. Echolalia, mimic others' phrases, or echopraxia, imitate actions of others. Patients in a catatonic stupor resist any effort to change their positions. They may suddenly excited from the state of stupor. During this phase they may become violent, shout excitedly, openly indulgence in sexual activity, attempt suicide, impulsively attack and try to kill others. Catatonic type of schizophrenia is seldom seen today because medications work effectively. 4.3 Paranoid schizophrenia. The person affected with paranoid schizophrenic shows suspiciousness and difficulty in interpersonal relationships. They are preoccupied with delusions or frequent auditory hallucinations. There are found no evidence of marked disorganized speech, disorganized or catatonic behavior, flat or inappropriate affect in paranoid schizophrenia. Illogical ideas and beliefs, often organized and coherent, are observed but in a delusional framework. Most prominent delusion is persecutory delusion, in which an individual may become highly suspicious of relatives or acquaintance and may complain of being watched, followed, poisoned, or talked about by enemies. Delusions of grandeur are also common in paranoid schizophrenia. Persons with such delusions may, for example, claim to be great leader or scientist or any prominent figure. 4.4 Undifferentiated type. Symptoms of schizophrenia that do not meet criteria for the disorganized, catatonic, or paranoid type are categorized under undifferentiated type of schizophrenia. Person with this type meets the Psychology paper number 15, Clinical Psychology. Usual criteria for schizophrenia but does not clearly fit into one of the other types because of mixed symptoms. 4.5 Residual type. When patients no longer meets the full criteria of schizophrenia but still shows some sign of the illness, then they comes under residual type of schizophrenia. This category is applicable for those people who have suffered at least one episode of schizophrenia but do not show any prominent positive symptoms such as hallucinations, delusions, or disorganized behavior or speech. Instead, clinical picture contains mostly negative symptoms, e.g., flat affect, although some positive symptoms may present in a mild form. 5. Epidemiology of schizophrenia. Prevalence. About 1% of adults are diagnosed as having some form of schizophrenia, APA, 2000. Prevalence rate appears stable across countries, culture, and over time, with the onset of problems typically beginning between the ages of 20 and 35 years. It is less common among children and adolescents than it is among adults. On average, women develop the condition 3 to 4 years later than men and show a second peak of onset around menopause. The lifetime morbid risk for developing schizophrenia is widely accepted to be around 1%. Gottsman, 1991. It means that 1 out of every 100 people born today who survive until at least age 55 will develop the disorder. Age of onset. The majority of cases of schizophrenia begin in late adolescence and early adulthood. The onset of problems typically begins between the ages of 20 and 35 years. On average, women develop the condition 3 to 4 years later than men and show a second peak of onset around menopause. Length of episodes. It is an episodic disorder, with periods of acute problems frequently separated by periods of remission. Wiersma et al. 1998 followed a cohort of individuals with schizophrenia for a period of 15 years following their initial episodes. 2/3 of those followed had at least one relapse, and after each relapse 1 in 6 did not recover, 1 in 10 committed suicide over the course of the study. Sex differences in schizophrenia. The gender difference has been found in every culture in terms of occurrence of schizophrenia. Interestingly, schizophrenia tends to begin earlier in men than in women. The average age of onset of schizophrenia is around 25 years for men and around 29 years for women. Jablonski and Cole, 1997. Many researchers believe that males develop a more severe form of the disorder. Leung and Chue, 2000. Socioeconomic status. Prevalence rate of schizophrenia is profound in low socioeconomic status. Stressors related with SES may cause or contribute to the development of schizophrenia. Sociogenic hypothesis. Psychology paper number 15, Clinical Psychology. Sociocultural factors. People of Afro-Caribbean origin living in the United Kingdom seem to have higher than expected rates of schizophrenia. Harrison et al., 1997. Rates of schizophrenia also seem to be high in Western Ireland and Croatia and especially low in Papua New Guinea. Gottsman, 1991. The Hutterites, a Christian sect that migrated to the United States from Europe in the late 1800s, also show a low prevalence of schizophrenia. Nimgaonkar et al., 2000. 6. Etiology of schizophrenia. 6.1 Biological perspective. Genetic vulnerability to schizophrenia. A good deal of research support that schizophrenia has a genetic component. Substantial data have been reported from investigations of family history and/or genetic variables for schizophrenia. These studies are of 4 types: family studies, twin concordance, adoption studies, and mode of transmission studies. Family studies. Many studies have revealed that schizophrenia is a familial disorder and runs in families. A study was done by Gottsman, 1991, to search out the genesis of schizophrenia, which is based on compilation from family and twin studies in European populations between 1920 and 1987. This study shows strong association between the closeness of the blood relations and the risk of developing the disorder. The prevalence of schizophrenia in the first-degree relatives, parents, sibling, and offspring of a proband with schizophrenia is about 10%. For second-degree relatives who share 25% of their genes with the proband, e.g., half-siblings, aunts, uncles, nieces, nephews, and grandchildren, the lifetime prevalence of schizophrenia is close to 3%. A study done by Suong 2000 indicated that the risk for schizophrenia among relatives of an identified case correlated with the degree of shared genes. It showed the strength of genetic linkages in schizophrenia. Rate of concordance was found high in families than general population. Twin studies. Several studies show a high concordance for schizophrenia among identical or monozygotic twins, 100% shared genes over people related in another way, including fraternal or dizygotic twins. Kringle 1993 have reported concordance rates for schizophrenia in monozygotic twins of between 30 and 40% and between dizygotic twins of 10 to 15%, suggesting a part genetically mediated risk for schizophrenia. Adoption studies. The Danish adoption studies Keedy et al. 1975 traced the biological relatives of 34 adopted children who later developed schizophrenia and those of 34 control cases with clean pedigrees and compared the prevalence of schizophrenia among them. They found only one person diagnosed as having chronic schizophrenia among the relatives of either case or controls. This critics provide no evidence that schizophrenia is inherited. A more recent study of genetics reported by Tianeri et al. 2000 compared rates of schizophrenia in the adopted away offspring of both mothers diagnosed with schizophrenia and those without the diagnosis. Risk for schizophrenia was 4 times greater among the children of the women diagnosed as having schizophrenia than among the children of the comparison mothers, a total comparison of 8.1% versus 2.3%. Schizophrenia has been a matter of debate over the role of nature and nurture in the development of mental health problem. Evidence relating to genetic factors has been closely scrutinized and has not been without controversy. It can be concluded from the studies reported that if genetic Psychology paper number 15, Clinical Psychology. Factors play role then its concordance rate should be 100% in identical twins but it has not been found. Wahlberg et al. 2000 reported an interaction between genetic and environmental factors. Role of biochemical factors in schizophrenia. Dopamine hypothesis. Dopamine is a neurotransmitter which plays major role in schizophrenia. Neurons mediated by dopamine are found in the limbic system, in a brain area known as A10, with links to the thalamus, hippocampus and frontal cortex. Dopamine hypothesis suggests that the experience of the people diagnosed with schizophrenia result from either an excess of dopamine, receptor supersensitivity to normal amounts of dopamine. Evidence of increased dopamine activity comes from a number of studies. Lieberman et al. 1990. Amphetamine use increases dopamine levels and can produce experiences that mimic the positive symptoms of schizophrenia. Some neuroleptic drugs like phenothiazines used for the treatment of both amphetamine psychosis and schizophrenia block transmission of dopamine by preventing its uptake at the postsynaptic receptor site. Dopamine hypothesis does not provide complete explanation. Schizophrenia is a disorder with widespread symptoms. It is unlikely that a single neurotransmitter could account for all of them. Glutamate may also play a role in schizophrenia. Carlson et al. 1999. Glutamate is an excitatory neurotransmitter that is widespread in the brain. In schizophrenia, low level of glutamate has been reported in affected persons. Faustman et al. 1999. Neurological anomaly. Some studies suggest that negative, disorganized and some positive symptoms may result from damage to the neural systems. Basso et al. 1998. The most common findings of brain scans include enlarged cerebral ventricles and decreased cortical volume, especially in the temporal and frontal lobe. Neurological deficits occur due to many reasons like excessive dopamine, viral infection, pregnancy and delivery complications, and maternal stress. Continued excessive dopamine activity leads to degeneration of the neurons in the dopamine systems, leading to exceptionally low levels of dopamine activity and hence negative symptoms. Lieberman et al. 1990. Viral infections may lead to schizophrenia. Young children who had viral infections were 5 times more likely to develop schizophrenia than those who did not. Jones and Cannon, 1998. Pregnancy and delivery complications may also cause brain damage that increases risk for schizophrenia. A meta-analysis showed that schizophrenic children were passed through complications like low birth weight, prematurity, lack of oxygen, etc. During pregnancy. Substance abuse. One biological trigger may also be implicated. Stimulants can cause transient psychotic experiences and precipitate relapse of an existing psychotic condition. Saddle and et al. 1991. Research suggests that cannabis consumption can also increase risk of schizophrenia. Andreessen et al. 1987. The cannabis raises levels of cerebral dopamine and might precipitate psychosis. 6.2 Psychosocial perspective. Psychodynamic explanation. Freud and other psychoanalytic theorists viewed schizophrenia as a retreat from unbearable stress and conflict. For Freud, schizophrenia represented an example of regression defense mechanism, in which a person follows an infantile and childhood pattern of behavior to feel secure and avoid the reality. Freud's regression explanation has not received direct research support. Fisher and Greenberg, 1996. Other psychodynamic theorists focusing on Psychology paper number 15, Clinical Psychology. The interpersonal withdrawal that is an important characteristic of schizophrenia, view the disorder as a retreat from an interpersonal world that has become too stressful to deal with. Role of life stressors as a causal factor is generally accepted. Ari and Sondhi, 2007. Behavioristic perspective. Behaviorist emphasizes the role of learning and acquisition of maladaptive behavior which causes psychopathology. Behaviorists do not try to account for the onset of schizophrenia but focus on how the behavioral symptoms of the different types of schizophrenia might be shaped through the process of reinforcement and extinction. Modeling may also play a part in the behavioral explanation of schizophrenia, as patients in hospital may see the bizarre behavior of other patients get rewarded with attention and later imitate similar behavior. Some influential theories attribute schizophrenia to processes of modeling. Bandura, 1968, or instrumental conditioning. Ullman and Krasner, 1975. This does not explain how people who have never been exposed to other schizophrenic develop their behavior. Cognitive perspective. Cognitive theorists see the irrational beliefs of the schizophrenia as a severe form of illogical thinking. Cognitive theorists believe that people affected with schizophrenia have attention-related defects in filtering out irrelevant stimuli. It creates overwhelming situation. The stimulus overload produces distractibility, thought disorganization, and the sense of being overwhelmed by disconnected thoughts and ideas. As one patient of schizophrenia reported, everything seems to come pouring in at once. I can't seem to keep anything out. Carson et al., 1988. Socioeconomic status. Prevalence rate of schizophrenia is profound in low socioeconomic status. Stressors related with SES may cause or contribute to the development of schizophrenia. Sociogenic hypothesis. But it is tough to establish causality. Individuals in lowest socioeconomic groups were 3 times more likely to be assigned a diagnosis of schizophrenia than those in the high socioeconomic group. Finding suggests that low socioeconomic may trigger the onset of schizophrenia in vulnerable individuals. In a study, 24% of episodes of schizophrenia seem to be precipitated by some acute life stress. Suong et al., 1986. Life experiences and family interaction. In case of schizophrenia, family can be a source of originating disease. Schizophrenia tends to run in families. People diagnosed as schizophrenic are likely to have at least one parent with the same diagnosis. Highly emotional family environments might be stressful to patients. Brown et al., 1958, observed that patients from hospital who returned home to live with parents or with a spouse were at high risk of relapse than patients who left the hospital to live alone or siblings. It indicates stimulating role of family in occurrence of schizophrenia. Expressed emotion is a measure of the family environment that is based on how a family member speaks about the patients during a private interview with a researcher. Some researchers focus on communication pattern in the family. Schizophrenia results from constant double-bind communication from one family member to other, typically from parent to child. Battison et al., 1956. In some cases, the verbal content of a communication may conflict with the physical or emotional content. Battison et al., 1956. For example, a young man whose mother visited him in his mental hospital was delighted to see her. He put his arm around her, at which point she stiffened. In response, he withdrew his arm, but then she asked, "Do not love me anymore?" Confused and embarrassed, he blushed and his mother said, "Dear, you must not be so easily embarrassed and afraid so easily." Some evidence does indicate that people diagnosed as Psychology paper number 15, Clinical Psychology. Schizophrenic often grow up in families where communication is disordered and where at least one parent is critical and over-controlling. Leem, 1980. Urban living. It seems that living in an urban setting may increase the vulnerability of schizophrenia. Some studies showed association between urban living and schizophrenia. In a study, it was found that children who spent the first 15 years of their lives living in an urban environment were 2.75 times more likely to develop schizophrenia in adulthood than who spent their childhoods in rural settings. Peterson and Mortensen, 2001. It indicates toward a possible role of the environment or nurture in schizophrenia. The social causation hypothesis attributes the higher prevalence of schizophrenia to the higher levels of stress that low-income people experience, particularly within urban environments. 6. 7. Treatment of schizophrenia. 7.1 Biological treatments. Pharmacological treatment. Most people diagnosed with schizophrenia receive some form of medication. Chlorpromazine, haloperidol and clozapine are 3 of the most commonly used drugs. Chlorpromazine and haloperidol seem to affect only the positive symptoms of schizophrenia, whereas clozapine is more successful at treating the negative symptoms and is often effective when other treatments fail. Antipsychotic drugs have been so successful in treatment of schizophrenia that stay in hospital has declined to less than 13 days than formerly longer time of stay. It works as a protective factor against relapse of disorder. Sardi and Kornos, 1990. Electroconvulsive therapy. ECT has been used as a major procedure in treatment of schizophrenia in the past, but it is less effective than antipsychotic drugs and useful for short-term improvement. Due to least effective mode, it has been curtailed with an increased emphasis on medication and psychosocial treatments. 7.2 Psychotherapy. Psychoanalytic therapy. One of the first psychological treatments of schizophrenia was developed by Harry Stack Sullivan in the early part of the 20th century. He considered that schizophrenia arises from the personal and social problems. His treatment involved examination of life history of the individual, historical roots and current ramifications of their maladaptive marked ambivalence interpersonal relationship. Resolution to this conflict through the psychotherapeutic process was thought to result in improvements in psychosis and maturation of the patient. Sullivan's approach of treatment has encouraged the use of psychological treatment of schizophrenia, but it has been found least effective and is no longer in use. Family interventions. Family therapy has been found effective in minimizing the strength of symptoms of schizophrenia. Family therapy reduces high level of expressed emotion. On the basis of related studies carried out in this field, Farrow et al., 2000 concluded that family interventions reduce risk of relapse by about half in comparison to medical care. It has also been noted that family interventions decrease the frequency of admission to hospital, time spent in hospital, and improved compliance with medical regimens. Psychology paper number 15, Clinical Psychology. Social skills training. Patients suffering from schizophrenia shows gross deficit in their interpersonal skills. They fail to recognize basic emotions such as happiness and anger. Hall et al. 2004. Social skills training make them able to function better. Social skills include employment skills, relationship skills, self-care skills, and skills in managing medication or symptoms. Patients learn these skills, get corrective feedback, practice their new skills using role-playing, and then use what they have learned in natural settings. Balak and Muser, 1993. The results of social skills treatments are mixed. Some studies showed improvement in specific skill that makes them function better. Kopolowitz et al., 2002. Other research studies have failed to find any significant improvements in patients' social functioning. Hoggerty et al., 1991. Problem lies because skills are domain-specific, whereas social functioning requires a broad range of skills. Cognitive behavior therapy. Cognitive behavior therapy has been found effective in the treatment of schizophrenia. Tarrier et al., 1998 found that patients who received CBT showed decreases in their hallucinations and delusions compared to patients who received either supportive counseling or routine care. Two forms of CBT are used in therapy of schizophrenia: stress management and belief modification. The goal of CBT is to decrease the intensity of positive symptoms, reduce relapse, and decrease social disability. Stress management involves working with individuals to help them cope with the stress associated with psychotic experiences. In a study, Tarrier et al. 2000 found that stress management intervention evidenced a greater improvement than other type of interventions. Belief modification involves attempts to change the nature of delusional beliefs the individual may hold. In this strategy, two cognitive interventions are used: verbal challenge and behavioral hypothesising to counter delusional beliefs and hallucinations. The patient is not told that the belief is wrong but is asked to consider an alternative view provided by the therapist. New possibilities may then be tested in the real world as appropriate. Reflecting the novelty of this approach, a meta-analysis was conducted by Jones et al. 2000, which showed that belief modification as an intervention reduced both the frequency and impact of hallucinations that is a prominent characteristic of schizophrenia. 8. Summary. Definition. The definition and diagnosis of schizophrenia has generated much debate and deliberation among clinical psychologists and psychiatrists. The general consensus deems schizophrenia as a group of psychotic disorders characterized by distortions of thinking and perception. It includes disturbances in thinking, speech, perception, emotion, and behavior. Herz and Marder, 2002. This definition, though widely accepted, cannot be said to be definite and is being continuously revised for accuracy and universality of diagnosis and treatment. One such revision of psychotic disorders led to the operationalization of schizophrenia spectrum disorder. Keeping in mind how broad and heterogeneous the symptoms of schizophrenia are, differing from individual to individual, Seymour Keedy in the 1960s proposed that schizophrenia, as it is strictly defined, represents one condition along a spectrum of mental disorders with varying degrees of severity. By viewing schizophrenia not as an all-or-nothing trait but rather as a highly graded one, Keedy provided a framework in which vulnerability to schizophrenia-like symptoms could vary over a wide range of values, from the totally unaffected individual to the severely impaired individual. Schizophrenia spectrum disorder is based on the dimensional approach to mental disorders. The dimensional approach characterizes mental disorders on the basis of how frequently and intensely symptoms such as hallucinations, for instance, are experienced rather than simply noting the presence or absence of symptoms. The term spectrum as it applies to mental disorders refers to the range of linked conditions and symptoms. The different elements of a spectrum either have a similar appearance or are thought to be caused by the same underlying mechanism. So we can define schizophrenia spectrum as a term used to group together the psychotic and mental disorders or personality types, each of which contain some of the symptoms of schizophrenia but at a less problematic or significant level. Other than schizophrenia, the other disorders encompassed by schizophrenia spectrum disorder are psychotic disorders like schizophreniform disorder, schizoaffective disorder, brief psychotic disorder, shared psychotic disorder, and odd personality disorders like schizoid personality disorder, schizotypal personality disorder, and paranoid personality disorder, as well as delusion disorder. Psychology paper number 15, Clinical Psychology. 3. Clinical picture. 3.1. Diagnostic criteria. The diagnosis of schizophrenia spectrum disorders in general can be found in the DSM-5 Diagnostic and Statistical Manual of Mental Disorders 5th edition, published by the APA, American Psychiatric Association, in 2013, under the chapter, Schizophrenia Spectrum and Other Psychotic Disorders. The manual differs slightly from DSM-IBTR where the diagnosis of psychotic disorders is concerned. According to DSM-5, schizophrenia spectrum disorders are diagnosed by keeping in mind three factors: domains, gradients, and dimensions of psychopathology. The mental disorder must represent abnormalities in one or more of the following 5 domains: delusions, hallucinations, disorganized thinking, speech, grossly disorganized or abnormal motor behavior, including catatonia, and negative symptoms. Gradient includes assessing the level of psychosis, number of symptoms, and duration of the psychosis to determine the severity of the disorder. Dimensional assessments capture meaningful variations in the severity of the symptoms, which may help with treatment planning and the prediction of course and outcome. Allardyce et al. 2007. The manual suggests that a patient must be assessed along 8 dimensions, the 5 domains described previously, as well as cognition, depression, and mania. Bark et al. 2013. 3.2 Detailed description of symptoms. The domains, or symptoms, of schizophrenia spectrum disorders are described as follows. Delusions. It is defined as fixed beliefs that are not amenable to change in the light of conflicting evidence. APA, 2013. Note that the term, erroneous beliefs, DSM-IBTR, has been omitted by DSM-5, since it is often difficult, if not impossible, to establish the non-veridical nature of a belief. Spitzer, 1990, Coulthard et al., 2011. There are various types of delusions. The most common is delusions of persecution. Here, the person believes that he or she is being spied upon or plotted against. Delusions of control are also very common. This entails the belief that other people, forces, or even extraterrestrial beings are controlling one's thoughts, feelings, and actions, usually through means of electronic devices communicating directly with the brain. Delusions or reference occurs when the person believes that he or she is being referred to by things and events that may actually have nothing to do with him or her. For instance, a schizophrenic patient may believe that his or her life is being depicted on a television series. Delusions of grandeur is also common. Here, the person believes that he or she is an extremely famous and powerful person. Some believe, for example, that they are some superpower, like Jesus, sent to save the world from destruction. Hallucinations. Hallucinations are sensory experiences that occur in the absence of any appropriate external stimulus. So, while delusions are beliefs held in the absence of reality-based evidence, hallucinations entail auditory, tactile, somatic, gustatory, visual, and olfactory experiences without any existing stimulus. Auditory hallucinations, wherein the patient typically hears one or more voices talking, are apparently the most common, occurring in 70% of schizophrenic patients. Cleghorn, Franco, Sheckman, et al., 1992, and certain types of auditory hallucinations are especially characteristic of schizophrenia, notably the experience of. Psychology paper number 15, Clinical Psychology. Hearing two or more voices that keep a running commentary on the patient's thoughts or behaviors. Miani and David, 1996. Visual hallucinations are the second most frequent in schizophrenic patients, wherein one sees non-existent persons or creatures. Ludwig, 1986. Tactile hallucinations are typically of tingling and burning sensations, while somatic hallucinations are experiences of something happening inside one's body, such as a snake crawling inside one's stomach. Gustatory and olfactory hallucinations are related to strange taste of food or drink and strange smells, usually of rotten flesh, urine, vomit, and smoke. Disorganized thinking. People with schizophrenia may not be able to think logically or may speak in peculiar ways. Formal thought disorders characterize this symptom. These make communication very difficult, with the patient shifting from one topic to another without keeping a normal structure intact. This is termed loosening of associations or derailment. Patients also invent new words or phrases called neologisms. Neologisms involve the combining of parts of two or more regular words, or the use of common words in a new way. Willerman and Cohen, 1990. For instance, a phrase like, father tie, for relative, and good ship, for good things. Researchers suggest that the use of neologism may not be from radical thought disturbances but rather from an inability to retrieve commonly agreed upon verbal symbols. That is, they just can't find the right words to use. Delices, 2001, Bark and Berenbaum, 1996. Clanging is another oddity in speech patterns of schizophrenic and manic patients. This is the pairing of words that rhyme, regardless of the meaning of such association. Example, a flump is a gump. Perseveration, or the persistent and inappropriate repetition of the same thoughts, is also a speech problem in schizophrenics. Abnormal motor behavior. People with schizophrenic symptoms have psychomotor abnormalities. They move less spontaneously or make odd grimaces and gestures. These symptoms may take extreme forms known as catatonia. People in a catatonic stupor remain motionless and silent for long stretches of time. Some show catatonic rigidity, i.e. maintaining a rigid, upright posture for hours. Others exhibit catatonic posturing, i.e. assuming awkward, bizarre positions for long periods of time. Catatonia can therefore be defined as an abnormal condition variously characterized by stupor, inactivity, mania, and either rigidity or extreme flexibility of the limbs. Negative symptoms. Negative symptoms of schizophrenia include symptoms that cause lack of ability in terms of social, emotional, physical, and psychological functioning. Alogia, or poverty of speech, is the lessening of speech fluency and productivity, thought to reflect slowing or blocked thoughts, and often manifested as short, empty replies to questions. Affective flattening is the reduction in the range and intensity of emotional expression, including facial expression, voice tone, eye contact. Person seems to stare, doesn't maintain eye contact in a normal process, and is not able to interpret body language nor use appropriate body language. Abolition is the reduction, difficulty, or inability to initiate and persist in goal-directed behavior. It is often mistaken for apparent disinterest. Examples of abolition include no longer interested in going out and meeting with friends, no longer interested in activities that the person used to show enthusiasm for, no longer interested in much of anything, sitting in the house for many hours a day doing nothing. Therefore, schizophrenics often lack emotion, energy, interest in life, social skills, and deeply engage in social isolation. Psychology paper number 15, Clinical Psychology. Other than these symptoms, the DSM-5 also suggests an evaluation of the person along the dimensions of cognition, depression, and mania. Cognition refers to the process of thinking which is usually slow, disorganized, and derailed for schizophrenics. They also have poor concentration, poor memory, and have difficulty in integrating and expressing thoughts. Depression refers to a negative affect and an aversion to activity that affects one's thoughts, behavior, feelings, and sense of well-being. Schizophrenic patients usually have a combination depression, negative symptoms, and impaired cognition. Mania refers to high arousal levels where emotions are concerned. A manic patient usually alternates rapidly between feelings of euphoria and irritability. He or she may seem enthusiastic, feeling wonderful about the world, and harboring many ideas while seeming absolutely reckless and hyperactive. Such people are also highly distracted and talkative. They usually have a decreased need for sleep, sleeping only 2 to 3 hours a day, but have twice as much energy as those around them. 4. Disorders under schizophrenia. Spectrum disorders. As described above, schizophrenia spectrum disorders entails disorders which produce symptoms similar to those seen in schizophrenic patients. These are some psychotic disorders such as schizoaffective disorder, schizophreniform disorder, shared psychotic disorder, and brief psychotic disorder. Included in the spectrum are also certain personality disorders such as paranoid personality disorder, schizotypal personality disorder, and schizoid personality disorder. Delusional disorder is also seen as a schizophrenia spectrum disorder. A detailed explanation of the disorders is as follows. 4.1. Psychotic disorders. Psychotic disorders are a class of psychological disorders wherein reality contact, the capacity to perceive, process, and respond to environmental stimuli in an adaptive manner, is radically impaired, with the result that the person cannot meet the ordinary demands of life. Fundamentally, these disorders are characterized by abnormal thinking and perceptions. These disorders are 4.1.1. Schizoaffective disorder. Individuals diagnosed with schizoaffective disorder typically have symptoms of both schizophrenia and severe mood disorder. This makes schizoaffective disorder a kind of hybrid disorder. In other words, the person has psychotic symptoms that meet criteria for schizophrenia but also has marked changes in mood for a substantial amount of time. Because mood disorders can be unipolar or bipolar in type, there are two subtypes of schizoaffective disorder, bipolar and unipolar subtypes. It is still not entirely clear whether schizoaffective disorder is best regarded as a variant of schizophrenia or as a form of mood disorder. In general, the prognosis for these patients is somewhere between that of patients with mood disorders. Walker et al., 2004. The DSM-IBTR states the presence of some mood disorder with symptoms of schizophrenia is a major criterion for the diagnosis of this disorder. The other criteria are that the mood symptoms be present for a substantial proportion of the total illness time and that the individual must have delusions and hallucinations for a period of 2 weeks at least in the absence of mood symptoms. Psychology paper number 15, Clinical Psychology. 4.1.2. Schizophreniform disorder. Schizophreniform disorder is a kind of short-term schizophrenia. The patient has schizophrenic symptoms such as delusions, hallucinations, etc., which are typical of undifferentiated subtype of schizophrenia. What makes schizophreniform disorder separate from schizophrenia is the duration of the illness. According to the DSM-IBTR, the diagnosis requires symptoms of schizophrenia to be present for 1 month at least but less than 6 months. If the psychosis persists beyond 6 months, then it is diagnosed as schizophrenia. 4.1.3. Shared psychotic disorder. Shared psychotic disorder, also referred to over the years as shared paranoid disorder, induced psychotic disorder and double insanity, and was first described by French psychiatrists, Lasiguet and Falleret in 1877. The disorder is characterized by the transfer of delusions from one person to another. Both persons are closely associated for a long time and typically live together in relative social isolation. The person who first has the delusion, the primary case, is often chronically ill and typically the influential member of the relationship. The secondary case is frequently less intelligent, more gullible, more passive or more lacking in self-esteem than the person in the primary case. The DSM-IBTR suggests that the diagnostic criteria for this disorder are that the delusion should develop in the context of a close relationship with another person and the content of the delusion should be similar to that of the person who already has the established delusion. 4.1.4. Brief psychotic disorder. Brief psychotic disorder is exactly what its name suggests. It involves the sudden onset of psychotic symptoms or grossly disorganized or catatonic behavior. Even though there is often great emotional turmoil, the episode is usually quite brief, often lasting only a matter of days, too short to warrant a diagnosis of schizophreniform disorder. After this, the person returns to his/her former level of functioning and may never have another episode again. Brief psychotic disorder is often triggered by stress. The DSM-IBTR states the diagnostic criteria based on the type and duration of symptoms. The patient must present of one or more of the following symptoms: delusions, hallucinations, disorganized speech or grossly disorganized or catatonic behavior, and the psychotic episode must last at least 1 day but less than a month, with an eventual return to normal functioning. 4.2. Personality disorders. The personality disorders that classify as schizophrenia spectrum disorders are the cluster of personality, odd, eccentric personality disorders as described by the DSM-IBTR. People with odd, eccentric personality disorders have some traits in common with victims of schizophrenia. Psychology paper number 15, Clinical Psychology. And delusion disorder, though they do not show the decisive break in reality that characterizes those very grave conditions. These include paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. 4.2.1. Paranoid personality disorder. As the name suggests, suspicion and paranoia characterize this disorder. People with paranoid personality disorder feel suspicious of almost all people in almost all situations, usually without any reality-based evidence. They tend to see themselves as blameless, instead blaming others for their own mistakes and failures, even to the point of ascribing evil motives to others. Such people are chronically on guard, constantly expecting trickery and looking for clues to validate their expectations, while disregarding all evidence to the contrary. For instance, if two people are talking together in a corner, or if the mail is late, or even if the neighbors are blaring loud music at night for various reasons, the paranoid individual regards these as evidence of personal hostility. They are often preoccupied with the loyalty of friends and hence are reluctant to confide in others. They commonly bear grudges, refuse to forgive perceived insults and slights, and are quick to react with anger. Bernstein, Uceda, and Siver, 1995, Miller et al., 2001. They are typically hypercritical, stubborn, and controlling. 4.2.2. Schizoid personality disorder. The defining characteristic of schizoid personality disorder is a severely restricted range of emotions, associated with social detachment. Such individuals are unable to form social relationships and lack interest in doing so. They also show disinterest in sexual activities. They are often distant from their families, they rarely marry, and they have no close friends. More generally, they are not very emotionally reactive, rarely experiencing strong positive or negative emotions, but rather show a generally apathetic mood. In extreme cases, emotions like joy, happiness, gaiety and pleasure, and negative emotions like disappointment, hurt or jealousy are not felt or expressed at all, sometimes leading to the identification of anhedonia, the absence of pleasurable emotions. These deficits contribute to their appearing cold and aloof. Miller et al., 2001, Rasmussen, 2005. 4.2.3. Schizotypal personality disorder. Individuals with schizotypal personality disorder manifest odd speech, behavior, thinking, and/or perception, but the oddity is not enough for a diagnosis of schizophrenia. For example, speech may ramble, but never to the point of actual incoherence, as is often the case with people with schizophrenia. Like schizoid personality disorder, schizotypal personalities also tend to be excessively introverted and have pervasive social and interpersonal deficits, and in addition, they also have cognitive and perceptual distortions and eccentricities in their communication and behavior. Miller et al., 2001, Whittaker, Trull, et al., 2002. Although contact with reality is usually maintained, highly personalized and superstitious thinking is characteristic of people with schizotypal personality, and under extreme stress they may experience transient psychotic symptoms. APA, 2000, Whittaker and Francis, 1994. They often believe that they have magical powers and may engage in magical rituals. Other cognitive perceptual problems include ideas of reference, the belief that conversations or gestures of others have special meaning or personal significance, odd speech, and paranoid beliefs. These symptoms, highly similar to those of Psychology paper number 15, Clinical Psychology. Schizophrenia, sometimes led them to be diagnosed first as exhibiting simple or latent schizophrenia. Researchers have found schizotypal disorder to be significantly more common among the biological relatives of people with schizophrenia than among the population at large. Mayer et al., 1994, Nicholson and Rapoport, 2001, indicating a possible genetic relationship. Furthermore, schizotypal personality disorder tends to respond to the same medications as schizophrenia. Schultz, and Wilson, 1988, a finding which suggests a biological relationship between the two disorders. 4.3. Delusional disorders. Delusional disorders, previously known as paranoid disorder, are a particular type of mental illness wherein delusions are the persistent and fundamental abnormality. A person with delusional disorder becomes headstrong about his beliefs regardless of any opposing evidence in reality. The person may present disturbances of moods, however this may only be a consequence of pursuing delusions. For instance, they may explode at a complete stranger but only because they suspect the stranger to be plotting against him, or any other delusion. People with delusional disorder often can continue to socialize and function normally, apart from the subject of their delusion, and generally do not behave in an obviously odd or bizarre manner. Furthermore, any other symptoms shown by the patient do not include the characteristic symptoms of schizophrenia, and the delusions are less bizarre than those of paranoid schizophrenia. The DSM-IBTR lists 5 categories, or types, of delusional disorders. The classic, and most common type, is the persecutory type, involving the belief that one is being plotted against, threatened or maltreated by others. The grandiose type entails delusions of grandeur with the individual believing that he or she has extraordinary powers and is famous. In the jealous type, the delusion is that one's sexual partner is being unfaithful. The erotomanic type generates the delusion that a famous personality, such as a celebrity, is in love with the person. Finally, the somatic type involves the false conviction that one is suffering from a physical abnormality or disorder. The somatic type is different from hypochondriasis, in that the person misinterprets bodily symptoms, example, weight loss means having cancer. Whereas, in somatic type, the person may have no symptoms to support his or her delusion, example, believing one has cancer because of a gut feeling. 5. Epidemiology of schizophrenia. Prevalence. The epidemiology catchment area study sponsored by the National Institute of Mental Health reported a lifetime prevalence of 0.6 to 1.9%. According to the DSM-IBTR, the annual incidence of schizophrenia ranges from 0.5 to 5.0 per 10,000. Schizophreniform disorder has a lifetime prevalence rate of 0.2% and a 1-year prevalence rate of 0.1 has been reported. The lifetime prevalence of schizoaffective disorder is less than 1%, possibly in the range of 0.5 to 0.8%. The prevalence of delusional disorder in the United States is currently estimated to be 0.025 to 0.03%. So, delusional disorder is much rarer than schizophrenia. The annual incidence of delusional disorder is 1 to 3 new cases per 100,000 persons. According to the DSM-IBTR 2000, delusional disorder accounts for only 1 to 2% of all admissions to mental psychology. Paper number 15, Clinical Psychology. Health facilities. The prevalence of paranoid personality disorder is 2.3% minus 4.4% of the general population. The prevalence of schizoid personality disorder is 3.1% minus 4.9% of the general population. Schizotypal personality disorder occurs in 0.6% minus 4.6% of the general population. Gender. Schizophrenia is equally prevalent in men and women. However, there are minor differences in the onset and course of the illness. Onset is earlier in men than in women. Some studies have shown that men are more likely to be impaired by negative symptoms and that women are more likely to have better social functioning than are men prior to disease onset. The prevalence of schizoaffective disorder has been reported to be lower in men than in women, particularly married women. In delusional disorder, women are more likely to develop this disorder, specifically erotomania. Men are more likely to develop paranoid delusion as part of delusional disorder. Brief psychotic disorder is seen as more prevalent in women than in men. Paranoid personality disorder is also more common in men than in women. Schizoid personality disorder and schizotypal personality disorder occur slightly more commonly in men than in women. Age. Schizophrenia has the peak ages of 10 to 25 years for men and 25 to 35 years for women. Approximately 3 to 10% of women with schizophrenia present with disease onset after age 40. About 90% of patients in treatment for schizophrenia are between 15 and 55 years old. Schizophreniform disorder is most common in adolescents and young adults. For schizoaffective disorder, the depressive type may be more common in younger persons, and the bipolar type may be more common in young adults than in older adults. The mean age of onset for delusional disorder is 40 years, but the range of onset runs from 18 years of age to the 90s. Brief psychotic disorder occurs more often in younger patients, 20s and 30s, than among older patients. Birth defects. Studies have pointed to gestational and birth complications, exposure to influenza epidemics, or maternal starvation during pregnancy, rhesus factor incompatibility, and an excess of winter births in the etiology of schizophrenia. Epidemiological data show a high incidence of schizophrenia after prenatal exposure to influenza during several epidemics of the disease. Substance abuse. Substance abuse is common in schizophrenia. The lifetime prevalence of any drug other than tobacco is often greater than 50%. In one population-based study, the lifetime prevalence of alcohol within schizophrenia was 40%. There has been particular interest in the association between cannabis and schizophrenia. Those reporting high levels of cannabis use more than 50 occasions were at 6-fold increased risk of schizophrenia compared to non-users. Up to 90% of schizophrenic patients may be dependent on nicotine. Recent studies have also demonstrated that nicotine may decrease positive symptoms such as hallucinations in schizophrenics. Cultural and geographical factors. The incidence of schizophrenia is higher for persons born in urban areas of industrialized nations. The incidence of schizophrenia in children of either one or two parents with schizophrenia is twice as high in cities as in rural communities. This suggests that social stressors in urban settings may affect development of schizophrenia in persons at risk. Relatives of patients with schizophreniform disorder are more likely to have. Psychology. Paper number 15, Clinical Psychology. Mood disorders and a diagnosis of psychotic mood disorder than relatives of patients with schizophrenia and mood disorder, respectively. Brief psychotic disorder seems to be more prevalent in people from developing countries and people who have experienced disasters or major cultural changes. Example, immigrants. Socioeconomic status. Patients with a diagnosis of schizophrenia are reported to account for 15 to 45% of homeless Americans. This points to the profound prevalence rate of schizophrenia in low socioeconomic status. For delusional disorder, association is seen with recent immigration and low socioeconomic status. Many of the delusional patients are also married and employed. Some clinicians claim that brief psychotic disorder is most frequently seen in patients from low socioeconomic classes. 6. Etiology of schizophrenia. There are a host of causes of schizophrenia spectrum disorder. These causes can be divided and understood as the biological or psychosocial factors. 6.1 Biological perspective. 6.1.1 Genetic factors. Schizophrenia, schizotypal, schizoid and paranoid personality disorders occur at an increased rate among the biological relatives of patients with schizophrenia. The likelihood of a person having schizophrenia is correlated with the closeness of the relationship to an affected relative. The following table shows the relationship between prevalence of schizophrenia in the population and genetic factors. The finding of a higher rate of schizophrenia among the biological relatives of an adopted away person who develops schizophrenia as compared to the adoptive, non-biological relatives who rear the patient, provides further support to the genetic contribution in the etiology of schizophrenia. Nevertheless, the monozygotic twin data clearly demonstrate the fact that individuals who are genetically vulnerable to schizophrenia do not inevitably develop schizophrenia. Other factors, such as environment, must also be involved in determining a schizophrenic outcome. Psychology paper number 15, Clinical Psychology. 6.1.2. Biochemical factors. Dopamine hypothesis of schizophrenia posits that schizophrenia results from too much dopaminergic activity. The major line of evidence for the dopamine hypothesis comes from research on the antipsychotic drugs, particularly the phenothiazines. These drugs seem to act on the schizophrenic symptoms and are used in treatment. So, their chemical activity, according to researchers, should provide a clue to the chemical activities underlying schizophrenia. The drugs work by blocking the brain's receptor sites for dopamine, that is, they reduce the activity of the parts of the brain that use dopamine to transmit neural impulses. Schneider and Deldon, 2001. Hence the dopamine hypothesis. Schizophrenia is connected to excess dopamine activity. Current hypotheses posit serotonin excess as a cause of both positive and negative symptoms in schizophrenia. Norepinephrine seems to be the cause of anhedonia, the impaired capacity for emotional gratification and the decreased ability to experience pleasure. GABA-gamma-aminobutyric acid has been implicated in the pathophysiology of schizophrenia based on the finding that some patients with schizophrenia have a loss of GABAergic neurons in the hippocampus. Acetylcholine and nicotine play a role in the regulation of neurotransmitters involved in cognition, which is impaired in schizophrenics. Neuropathology refers to the neuropathological basis, or neural problems, for schizophrenia, primarily in the limbic system and the basal ganglia, including neuropathological or neurochemical abnormalities in the cerebral cortex, the thalamus, and the brainstem. Computed tomography, CT scans, magnetic resonance spectroscopy, and electrophysiology studies have shown that there is reduced symmetry in several brain areas, volume shrinkage or neuronal loss in the thalamus, and decrease of size of the amygdala and the hippocampus in patients with schizophrenia. All these changes in the brain areas affect hunger, sexual impulses, emotional regulation, cognition and motor coordination. 6.2. Psychosocial perspective. 6.2.1. Psychoanalytic theories. Sigmund Freud postulated that schizophrenia resulted from developmental fixation that occurred earlier than those culminating in the development of neuroses. These fixations produce defects in ego development, and Freud postulated that such defects contributed to the symptoms of schizophrenia. Ego disintegration in schizophrenia represents a return to the time when the ego was not yet, or had just begun, to be established. Because the ego affects the interpretation of reality and the control of inner drives, such as sex and aggression, these ego functions are impaired. Thus, intrapsychic conflict arising from the early fixations and the ego defect, which may have resulted from poor early object relations, fuel the psychotic symptoms. Other psychodynamic theorists focusing on the interpersonal withdrawal that is an important characteristic of schizophrenia view the disorder as a retreat from an interpersonal world that has become too stressful to deal with. Role of life stressors as a causal factor is generally accepted. Arian Sondhi, 2007. 6.2.2. Behavioristic perspective. Behaviorists emphasize the role of learning in acquisition of maladaptive behavior which causes psychopathology. Behaviorists do not try to account for the onset of schizophrenia but. Psychology paper number 15, Clinical Psychology. Focus on how the behavioral symptoms of the different types of schizophrenia might be shaped through the process of reinforcement and extinction. Modeling may also play a part in the behavioral explanation of schizophrenia, as patients in hospital may see the bizarre behavior of other patients get rewarded with attention and later imitate similar behavior. Some influential theories attribute schizophrenia to processes of modeling. Bandura, 1968, or instrumental conditioning. Ullman and Krasner, 1975. This does not explain how people who have never been exposed to other schizophrenic develop their behavior. 6.2.3. Cognitive perspective. Cognitive theorists see the irrational beliefs of the schizophrenia as a severe form of illogical thinking. Cognitive theorists believe that people affected with schizophrenia have attention-related defects in filtering out irrelevant stimuli. It creates overwhelming situation. The stimulus overload produces distractibility, thought disorganization, and the sense of being overwhelmed by disconnected thoughts and ideas. As one patient of schizophrenia reported, everything seems to come pouring in at once. I can't seem to keep anything out. Carson et al., 1988. 6.2.4. Family dynamics. Biological therapies. Psychology paper number 15, Clinical Psychology. 7.1.1. Pharmacotherapy. Administration of antipsychotic medications entails the pharmacological strategies to treat schizophrenia and likewise disorders. Antipsychotics can be categorized into two main groups: the older conventional antipsychotics, also called first-generation antipsychotics or dopamine antagonists, and the newer drugs, called second-generation antipsychotics or serotonin dopamine antagonists, SDAs. Chlorpromazine thorazine has been shown to effectively reduce hallucinations and delusions, as well as excitement. Antipsychotics diminish psychotic symptom expression and reduce relapse rates. Approximately 70% of patients treated with any antipsychotic achieve remission. Sardi and Kornos, 1990. Patients of schizophreniform disorder respond better to medications than do patients of schizophrenia. In one study, about 75% of patients with schizophreniform disorder and only 20% of patients with schizophrenia responded to antipsychotic drugs like risperidone within 8 days. Patients of schizoaffective disorders are commonly administered antidepressants and mood stabilizer drugs. For the treatment of brief psychotic disorder, antipsychotic drugs are administered with benzodiazepines for the short-term treatment of the psychotic disorder. 7.1.2. Electroconvulsive therapy. Electroconvulsive therapy (ECT) is the administration of electric current to alter the neuronal activity and the behavior of neurotransmitters in the body. ECT has been shown to be as effective as antipsychotic medications and more effective than psychotherapy. In some cases, antipsychotic medications are administered with ECT. Psychology paper number 15, Clinical Psychology. 7.2.3. The therapist can art therapies. Many schizophrenic and schizoaffective patients benefit from art therapy, which provides them with an outlet for their constant bombardment of imagery and emotional upset. It helps them communicate with others and share their inner, often frightening world with others. Other forms of therapy, like vocational therapy, is used to help patients regain old skills or develop new ones. Group therapy is also a form of effective treatment wherein schizophrenic patients are gathered and the focus of the discussion is on real-life plans, problems, and relationships. These forms of therapy are effective in reducing social isolation of patients.